Hello, my name is Ben Spiegelberg. I'm a trauma and orthopaedic surgeon with a subspecialty interest in hip and knee surgery. I work at the Lister Hospital, the Wellington Hospital, and Spire Bushy Hospital. Hip arthritis is a condition whereby the cartilage that lines the joint becomes progressively more worn. The cartilage provides a spongy cushioning to the joint, and when that cartilage is worn out, the joint has lost its protective cushioning, and therefore pain and restricted range of motion is felt. The pain from hip arthritis is felt predominantly as groin pain. Patients can complain of a C-shaped distribution to the pain around the hip joint. It can also, on rare occasions, be felt as referred pain, whereby pain can be transmitted down the leg and be felt as pain in the knee. This can also be from the hip joint itself, but predominantly hip arthritis causes pain in the groin and also restricted range of motion. The early signs and symptoms of hip arthritis can be felt as a gradual niggling pain in the hip joint. The pain can progress and result in reduction in range of motion, and the first movement that tends to be lost is internal rotation in flexion, and that is what can cause the initial pain. Patients can then progress to develop pain that occurs at night time and can wake them up at night. And also patients can notice a restriction in functional tasks, such as bending forwards, tying shoelaces, cutting toenails. So the stages of hip arthritis can be classified as patient-reported stages and surgeon-reported stages. From the patient's point of view, the stages can reflect a change in the function and the abilities of what the patient can achieve. As the pain deteriorates, the range of motion and the ability to perform various activities can be reduced. And this is obviously the most important thing from the patient perspective. From a surgeon's point of view, the stages of arthritis can be classified as early, moderate, severe. And often that involves us getting a plain X-ray and looking at how the hip joint looks on the X-ray. And the stages can develop from as the cartilage reduces, the joint space narrows, and that sort of progression through early, moderate, severe results in progressive joint space narrowing to a stage where in severe arthritis, it becomes bone-on-bone arthritis when there is no cartilage remaining and the two bony surfaces are rubbing against each other. And certainly in that situation, where it is end-stage arthritis, a hip replacement is the only treatment that can be offered. The treatment of hip arthritis depends on the severity of the arthritis, what stage the arthritis is at. The early stages of arthritis can be treated with physiotherapy to work on strengthening of the muscles and improving the range of motion in the hip joint. Injections can also be used. Steroid and local anesthetic injection, particularly with arthritis, patients can develop an inflammatory reaction and the joint can become inflamed and swollen. And in the hip joint, there's not much room for swelling. And if the hip develops an effusion, this can be very painful. So an injection whereby some of the fluid is drawn off and steroid and local anesthetic is instilled into the joint can be very helpful in the early treatment of arthritis and allow patients to progress further with their physiotherapy. Some ancillary treatments can also be successful in the early stages, acupuncture being one. Moving forwards as the arthritis becomes more deep set, treatment in terms of hip preservation can involve hip arthroscopy. But once hip arthritis has become established and patients are at the moderate to severe end of arthritis, then really a hip replacement, if the non-operative treatments such as injections and physiotherapy do not work, then a hip replacement is the treatment of choice. Exercises that can help hip osteoarthritis, particularly in the earlier stages, are strengthening exercises for the muscles, particularly the gluteal muscles around the hip. They're really one of the most important muscles in terms of hip control and stabilizing the hip joint. So, yeah, with physiotherapy, those exercises are predominantly what's concentrated on. Exercise in terms of preserving the hip joint when there is established arthritis, it's exercises that don't put too much force through the knee joint. So running can be quite a lot of impact through the hip joint, and so running on particularly hard surfaces can be not advised. So running on a treadmill where it's a bit more cushioned, or moving towards exercise which is less load impact bearing. So cycling in particular, swimming as well, really good exercise in preserving the hip joint and maintaining muscle strength. When a hip replacement is indicated, I perform a hip replacement via the posterior approach. There is a lot of talk at the moment about the optimal approach for hip surgery, and there's been a lot of talk more recently about the anterior approach for the hip. I practiced this approach on fellowship and learnt the approach on fellowship, but didn't feel that it was a particularly beneficial approach. There is now increasing evidence in the literature that although patients at the 6-week mark are progressing better following a direct anterior approach hip, at every other post-operative mark after that, a posterior approach is the same, if not better. And there is increased literature that has been published to show that there are far more complications following a hip replacement by the anterior approach than by the posterior approach. That is increased risk of infection, increased risk of fracture, and there is a debate as to whether the anterior approach is true muscle sparing, as often the piriformis tendon requires to be cut during a direct anterior approach, and this is not repaired, whereas in a posterior approach, this tendon is repaired. So I feel that my patients do better with a posterior approach and have equal function by 6 weeks following the surgery compared to any other approach.